much for joining today's webinar. I'm Dr. Prachi from Shield Healthcare, and we are bringing episode U, which is all about urogynecology. So A to Z series, Trending Hour series is brought to you by AGOG. So let us have a quick introduction of AGOG followed by prayer.
वक्रतुंड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा।
It is my honor and pleasure to introduce today's coordinators. We have Dr. Ruchika Garg with us. Ma'am is a professor at SN Medical College, Agra. And Dr. Tanushree Pandey Patkaukar. Ma'am is an obstetrician and gynecologist, laparoscopic surgeon, IVF specialist at Dr. Patkaukar's clinic in Mumbai. So with this, I hand over this session to our esteemed coordinators. Over to you, ma'am.
Yeah, thank you, Dr. Prachi. So today we are very lucky to start this session of U series, which is the brainchild of Dr. Komal Niranjan Chavan, who is the main convener for this webinar. So I am inviting Dr. Komal Chavan. She has so many awards to her credit. She is ex-honorary professor R.N. Cooper Hospital, and she is the shining star of Foxy. Currently, we can find her in so many CMEs, and she is spreading knowledge everywhere. She is also the chairperson of Foxy Medical Disorders in Pregnancy Committee till now, and she has held so many posts, including managing committee member of MOGS, and recently she has won M.A. Pandit and Shalja Pandit Women Empowerment Award, and her Foxy Medical Disorders Pregnancy Committee also achieved got the Mehru Darra Best Committee Award, and she has been awarded the Dhira Foxy Award and so many appreciation awards, including the Nari Shakti Sama. So over to Komal Chavan, ma'am. Welcome you, ma'am. We also have the next convener, respected Dr. Niranjan Chavan sir with us, who is also the convener for this program. He is holding so many posts. He is the joint treasurer of Foxy. He was the president of MOGS, and he's also the member of Oncology Committee of SAFOG. And he is dean, and he's editor-in-chief of this Academia Global Journal, and he has so many awards and publications to his credit. So I welcome Dr. Niranjan Chavan, sir.
Thank you, Dr. Ruchika. I think for the lovely introduction, and I welcome all of you for this trending Ask the Expert series. Today's episode U is focused to urogynecology, and we are in the end of our series. And we had a real lovely time with this focused topics for Ask the Expert series, and a lovely experience it has been coordinating this series and learning from all the pioneers and legends we have today. So today's talk is going to focus by SUI by Dr. J B Sharma, and we have overactive bladder and SUI, all these topics and infections. And we have speakers, Dr. J B Sharma, Dr. Aparna Hegde. I think they are really par excellence in their subjects. And what can I say about our chief guest and guest of honor? We have our legendary Madam Chandravati Madam, who is going to be the chief guest, and a urogynecology experienced person in himself, Dr. Vineet Mishra, who has joined as a guest of honor. So I take pleasure to invite Dr. Chandravati Madam, and she is a Professor Emeritus Department of Obstetrics and Gynec at KG Medical College, Lucknow. She is a teacher par excellence. So many conferences she has organized, and I am really fortunate to be present at both her AICOG Lucknow conference, and the memories are really so great. She's managing trustee of the Krishna Educational Foundation at Lucknow, secretary NGO Wheel Women Empowerment, and patron of ICMCH, NARCHI, LOGS, so many organizations, vice president of FOXY, UP chapter of OBGYN Lucknow, governing council member of ICOG, and peer reviewer of Jogi Journal. And Madam, I think has the most respectable person in North India. And we really have to learn lots from her, how to carry it out for this all over so many years. She has been doing this, and she's an inspiration to all of us. So we are eagerly waiting to hear from you, Madam. Over to you to address the audience.
Thank you, Komal, for first thing for inviting me. It is always a pleasure to come to any program. Yours and Niranjan, and I know you have been working so hard. You have been to Lucknow lately for our conference and meetings here. It is really wonderful that you have been organizing this program under this aegis for so many times, and this is the last program before your great election goes on, and we are all eagerly waiting for your success in this election. My good wishes to this today's workshop today, what we have organized, because all the three speakers are par excellence, including you. So you are also one of the speakers for today's program. But I know J B Sharma, I've been hearing J B Sharma and Aparna both. I know they are par excellence in their field, and they will be doing justice to their talks. Besides this, I know that, for all urinary symptoms, we all understand, especially in UP, women, for the first time, they would go always to a gynecologist. Their first contact is a gynecologist. So it is very important for us to be aware about all these problems. And if we find something extraordinary, I know we have Vineet somewhere where we can always refer our patients, and he will be doing justice to those patients. And I really wish success to today's program, and I'm anxious to meet and see Vineet and hear his guest of honor speech, because for a long time I haven't met him and I haven't seen Vineet for such a long time. So Komal, wishing you again a great success. My all blessings are with you, and whenever you do anything, I'm there always behind you. Thank you, Komal and Niranjan, both of you. Thank you.
Thank you so much, Madam, for your lovely words and your blessings. And your blessings truly made my day. I'm so happy that you have been here today, accepted the invitation to be the chief guest. We are really, truly honored. And looking forward to visit Madam Lucknow. It is always a pleasure to come to Lucknow. And I remember coming a number of times. And I think in this last time since the ICOG, again, twice I have visited for the UPCon and the Lucknow CME. So I want to come again and again. I will keep coming to Lucknow and meet you, Madam. Thank you so much.
Okay, thank you. Thank you so much.
And now I call upon our guest of honor, Dr. Vineet Mishra. Vineet Mishra, we all know he is a doyen and a legend from Ahmedabad. He's a director of IKDRC and head of the Department of Institute of Kidney Dialysis and Research Center, practicing at Dr. H.L. Trivedi Institute of Transplant Sciences. He underwent fellowship training at University of Pittsburgh, USA, Seoul National University, South Korea. Published many articles in peer review and national and international journal. Research in fields of STEM, SUI, female sexual dysfunction, and he has also been the head of affair at FOXYs as a vice president in 2016. So many Urogynec conferences organized in Ahmedabad. I attended almost all. So really happy to be part of his programs. They are really very interactive and most sought for, and a great learning experience. His students are also all over and they are also doing so well. So he's teacher par excellence and he's a guide and mentor to me too. So Dr. Vineet Mishra, sir, over to you to address the audience.
Hi, good morning, ma'am. Good evening. Good afternoon.
We welcome J B Sharma, sir.
Kindly unmute, sir. Vineet, sir. Yes.
Okay. So, yeah. Komal, thank you. Thank you for inviting me and giving me this honor. But you know what is? Yes, I am able to see Anuj there, your husband. But the best part that I liked was I am face to face seeing Madam Chandravati. And you know, we call her Mai. Mai means mother, or she is mother to me. And let me share a secret. It is always nice to see even Ruchika there from Agra, Nita from Ahmedabad. We have Poonam. We have the J B Sharma. J B boss is there. We have Ami Ben, and of all, we have Aparna. It is nice to see, you know. And Komal, you have done a great thing bringing so stalwarts, especially Chandravati madam. It is, you know, always nice to see her and take her Ashirwad. And let me share you one secret which none of you know. Nita, Madam Chandravati is from Ahmedabad, is from Gujarat. Can you imagine?
Yes.
And
I know
for generations before, they migrated to UP, and now, yes, she is that stalwart, and stalwart of her capacity. Probably very few exist in this country. It is always nice to see her, the energy that she has, and the blessing that she gives, you know. But I am aghast with the technology which is there. Can you see? Komal is traveling and Madam Sabharwal is traveling. And then also we are in a conference and in an academic feast. So now probably all conferences, all Foxy conferences, everything should be on Zoom and WebEx. Am I right, madam? है ना मैडम आम होना चाहिए क्या लेके सब जगह पे भागो ये करो इसकी जगह पे there can be conferencing knowledge sharing right on WebEx and Zoom. But the initiative, Komal, that you have done is excellent. I have all my blessings to you. I have always called your husband as Anuj, as my younger brother. And वो खाली थोड़ा अनुज है ना बदमाश है. Only you can control Anuj. I tell him on his face, Madam Chandravati, वो लड़का बहुत अच्छा है. पर क्या है, हाँ, उसको क्या कहते हैं, कोमल कंट्रोल कर रही है तो बहुत अच्छी बात है. That is on little bit on personal basis. But Komal, all the best. And you, whatever venture you do in Foxy or any organization, we are all with you. All our blessings are with you. So everything good should happen. And let us enjoy the academic feast, the stalwarts that you have brought on the platform, which is big thing. Thank you, Komal, for giving us that opportunity. At least you made my day when I got darshan of Chandravati mat. And all my this thing, you know, Ruchika runs journals and everything, doing big thing in Agra. I have Nita is there. Though she is from Gujarat, Ahmedabad, but I have not met her since quite a time, but it is always nice seeing her on Zoom. JB boss, the big man.
No, sir.
And still bigger is Aparna. Aparna is मतलब वो कहते हैं ना मैडम कि कोई लोग मतलब वो गली में क्रिकेट खेलते हैं ना हम उसको फलिया कहते हैं, फलिया में क्रिकेट खेलते हैं। कुछ लोग क्या कहते हैं, डिस्ट्रिक्ट में क्रिकेट खेलते हैं। पर जो सही, जो बड़ा क्रिकेट खेलते हैं ना मैडम, वो सिर्फ क्या कहते हैं, JB शर्मा साहब हैं जो इंटरनेशनल उसमें हैं, और क्या कहते हैं, अपर्णा है। थैंक यू कोमल, ऑल द बेस्ट।
Thank you so much, sir, for the lovely words and some lighter moments in your talk. They were really heartening, and thank you for being here and blessing us. Your support means a lot to me, and I look forward to it. And thank you, Chandravati madam and Dr. Vineet Mishra sir, from bottom of my heart.
Komal,
for gracing-
I have a meeting. Some of my time goes
Yes,
to Gandhinagar, so I have a meeting. I will probably
Okay.
join you in between. Thank you,
Yes, sir.
everybody.
Sure, sir.
हाँ,
Looking
प्रणाम
forward.
मैडम।
Thank you,
प्रणाम
thank you.
आशीर्वाद,
सबको
हाँ,
नमस्ते।
प्रणाम आशीर्वाद दे दो मैडम, जूम पे ही दे दो, है ना, जूम पे ही दे दो,
पक्का
बिल्कुल, दोनों हाथ से।
दोनों
पक्का
हाथ।
आशीर्वाद, पक्का
पक्का।
पूरा दिल से।
सबको
बिल्कुल
आज
मैम।
मैडम का आशीर्वाद मिल गया है। चंद्रावती मैडम has blessed us all.
Thank you,
Yes.
thank you. everyone.
Thank you.
Thank you so much. Thank you for all your blessings, and it means a lot. With that note, I will hand over back to Ruchika to take forward the scientific proceedings. We are waiting eagerly for Dr. J B Sharma's talk. Thank you.
Yeah. Dr. Prachi, please post the. Yeah. Please post the CVs. So I would like to welcome Dr. J B Sharma sir for that. For the chairpersons of the session we have senior consultant Dr. Ami Mehta madam. She is from Rajkot, and she is the past president of Rajkot Menopause Society, and she is also the past president of Rajkot Obs-Gynae Society. Welcome, Ami ma'am. So now we have our esteemed Dr. Nita Thakrey ma'am. She is the past chairperson of Foxy Urogynae Committee, and she has so many awards and everything to her credit. She is also the ex-assistant professor of IKDRC Kesar Sayal Medical College, Ahmedabad, and she is senior consultant at KD Hospital in Ahmedabad, and she has been writing blogs for the Times of India. Welcome you, ma'am. We now have Dr. Professor Poonam Yadav with us. She is professor in SN Medical College, Agra, and she has so many awards to her credit, including the Foxy Corion Award for her research. And she has written a book of medical disorders in pregnancy, which was awarded Foxy DC Datta Award. And she is currently the secretary of Agra Obs-Gynae Society. So welcome, Dr. Poonam Yadav. So I now invite Ami madam to kindly introduce J B Sharma sir and welcome him for his talk.
Good evening, everyone. To discuss overactive bladder, we have with Dr. J B Sharma sir from AIIMS, Delhi. It is said that doctors save the lives and teacher make the lives, and sir is both. Sir has done his urogynec from King's College London and started fellowship on it also, and he has published more than 350 books. He has published the chapters. We are eagerly waiting to listen the sir. So over to you, Dr. J B Sharma sir.
Okay. Yeah. Thank you very much. At the outset, I thank Madam Komal Chavan madam for inviting me here, and respected chairperson Dr. Ruchika, and it's great to have blessings of Chandravati madam and Dr. Vineet Mishra and my colleague Dr. Nita Thakrey, and so thank you very much. So we now go to the overactive bladder syndrome. I mean, can you see my slides, ma'am? Oh, sorry. Yeah, we are just trying to say.
Yeah.
Yeah. Okay. Okay. You can see the slides, ma'am?
Yes, sir.
Okay, okay. Yeah, so again, thanks a lot, and Dr. Komal, madam. So we'll be discussing about overactive bladder syndrome, and we know that how common it is. I mean, and it really, the patient who are suffering from it, they're really troubled by it, and so are the gynecologists who attend to these patients. So we know that International Continence Society has done like definition of it, as well as International Continence Society, and so overactive bladder syndrome as urgency with or without urge urinary incontinence, or usually it is with frequency and nocturia. There is no proven or identifiable infections, metabolic disorder, or other obvious urethrovesical pathologies in this case. So in other words, these patients have got basically urgency, frequency, nocturia in absence of urinary tract infection. So that's what I tell my postgraduate, that symptoms of UTI in absence of UTI is called overactive bladder syndrome. That means the patient has to go, she cannot control. Unlike stress incontinence, in which raised intra-abdominal pressure causes leaking, they say, in this case, there is no such leaking. The patient has to go, she has to go. So that means she may be getting up 7-8 times in the night, 10 times in the daytime, like that. Almost 2/3 of the patients with this do not have incontinence, and overactive bladder can be further classified as OAB wet with incontinence and OAB dry without incontinence. How to differentiate? Wet means she leaks also, and in dry also that she has the sensation as if she wants to go to the washroom, but she not incontinent, she doesn't leak urine. So we call it OAB dry, but she is troubled by the symptoms. So it's not that that's not a problem, that's also equal problem, and so we have to treat both of them. And the prevalence of overactive bladder syndrome in patients of more than 40 years, usually 1 in 6 persons will have it, almost like you can say 12% or so. And most commonly reported symptom is frequency, 85%, and other symptoms are urgency, 54%, urge incontinence, 36%, and almost 60% of respondents with symptoms consult a doctor, but only 27% receive treatment. So it's like just like hypertension patient, many only 60% go to the doctor, and then only 27% receive treatment. So many patients are suffering in silence. That is what we don't want actually. We know that in control of micturition basically include the sympathetic and parasympathetic system under the control of higher centers, including the brainstem, pons, and cerebral cortex. So sympathetics are inhibitory, parasympathetic S2 to S4, they are stimulatory. And then we have got muscarinic receptors M1 to M5, especially M3. This is important because when we are like using the drug, they usually should be working on M3 receptors. So this is the same thing. Pontine maturation center is there, and from there we get sympathetic T10 to L2 and parasympathetic S2 to S4, and we have got pudendal nerve also S2 to S4, which has got a voluntary control basically. So when the patient basically is not passing in at that time, sympathetic is dominant, and that will sympathetic will basically relax the bladder and constrict the urethra. While parasympathetic comes into action when patient has to pass urine, so that will cause contraction of the bladder, that means detrusor, and relaxation of the urethra. In addition to that, pudendal nerve can cause voluntary stoppage of passage of urine. So same thing basically again we have discussed, same thing we have discussed already. So what is the diagnosis? Most important is the basically clinical diagnosis based on history and symptoms. That's what I tell my postgraduates, that whenever you are seeing a urogyne patient, please do spend some time on the patient, take her history in detail. You need to spend more time with her. Then only we need to investigate to rule out any other infection, organic structural etiologies, and urodynamics are not necessary, as the diagnosis usually of overactive bladder syndrome can be seen without that also. But rarely in complicated case, mixed incontinence or failed surgery, then we can do urodynamics also. In urodynamic study, we will see basically detrusor overactivity during filling phase. So this is the history, taking that detailed history of urological symptom, off-scanning symptom, any neurological condition of the patient, any medical condition like diabetes, hypertension, surgical conditions, any patient had past history of surgery, social, psychological factors, radiation, pelvic trauma. All these are important. Like those patients of CA service who had radiation therapy, their bladder becomes very constricted, so they tend to have urge incontinence or small bladder. Similarly, patient with thimble bladder, past history of tuberculosis, their bladder is also very small. Then I talked about diabetes, and a patient on antihypertensive therapy, especially like diuretics. So these patients tend to pass more urine. Then detailed history taking of how much water she is taking. Some patients are taking too much tea, too much coffee, too much water intake. So that also can make the patient to pass urine. So all this history taking is important. Any past history of trauma. And one of my patients had past history of meningomyelocele treated in her childhood. Similarly, other patient had multiple sclerosis. So these are important conditions where you need to, avoid. And then the incontinence history, any characterization of incontinence, exactly how many times he passes urine a day. And it's a good idea to use any of the questionnaire. There are international questionnaire available free of cost on the from the internet. We can download any of them, like King's Health questionnaire is there, incontinence questionnaire, ICIQ is there. So any of the questionnaire we can use. Then length and severity of symptoms, how long patient has been having, 1 year, 2 years, and severity, how much it is affecting the quality of life. So that is important, impact on quality of life and associated bowel problem. In quality of life, it's also important. Many patients, like, they can't even go out in the market. They can't go to the temple. They can't, go to parties. So that is a severe impact on quality of life. Or sometimes they have to use like diapers, etc. So that you have to take in detail history and associated bowel symptoms also. On examination, again, systematic vaginal and pelvic examination. Apart from that, before I will talk to general physical examination, including neurological examination, mental status of the patient, mobility, lumbar, sacral, sensory, motor, BC reflex, anal wink, knee, ankle, artery. So what I meant to say, neurological examination is very, very important for these patients, which we normally don't do in a gynae patient. While we are examining the patient, then of course, any anemia, pallor, any thyroid, any JVP raised, heart chest examination, because some patient may have, chronic obstructive airway disease, so they may have rage and bronchi, etc. Because that is important for post-operative condition also, pre-operative condition also, and that has to be treated along with the urgent incontinence or urinary incontinence. Then on local examination, condition of the mucosa, there can be urogenital atrophy in absence of estrogen in elderly patient, and topical estrogen therapy may be useful for such patient. Urethral mobility to rule out causative test and all, and demonstration of incontinence basically. Then any associated prolapse, anterior wall, posterior wall, apical prolapse. Bimanual examination is also important. So all these, sometimes they can be, I've seen 2-3 cases in which there was a big fibroid pressing on the bladder. Patient had, incontinence because of that. Another patient had retroperitoneal tumor, which was pressing on the, everything was being pushed down. So some patient may have those symptoms, and that can, cervical fibroid, another condition. So these are important conditions. Then we do ancillary tests like voiding intake diary. That's very important. Usually 1 week diary is used, but there is a 48 to 72 hours diary also, or the weekend diary. So in that case, we give the diary patient notes from the beginning only, like she gets up at say 5 o'clock in the morning. So from till that, till she sleeps. So she writes how much fluid she took, including all tea, coffee, any drinks or water, etc. So total amount on the left hand side, right hand side, whenever she passes urine. So we calculate it, and this is important. I have seen at least 3 to 4 or 5 patients. Every patient was drinking almost 4.5 to 5 liters of water. So there's this concept going on that if we drink too much of water, it is good for our facial glow, etc. So please, too much of water is not good, because that can cause patient incontinence. So we need 1.8 to 2 liters for our renal function proper, so that we shouldn't take more than that. Then overactive bladder, incontinence diary, the same thing I talked about. Urine analysis, basically we need to do urine culture and cytology just to rule out urinary tract infection. Post-void residual sometimes is there that you can calculate with the ultrasound, and usually it should be less than 50 ml, or sometimes some people say more, less than 80 ml also. And pad test can be used in this case. We give a pad to the patient, we weigh the pad, like suppose it was 10 gram before, and then we patient wears it, and then after say 10-15 minutes he walks with that, and then we again test it. So that if the weight is more than 1 gram before, that means he has leaked during this time. So then the role of cystometry we have done that, defining underlying pathophysiology, bladder filling, involuntary detrusor contraction, low bladder compliance, urethral obstruction, impaired detrusor contractility, and directing treatment. So this can be rolled, but routine cystometry or urodynamics is not required really, but only complicated cases we need to do. But if you do, then and that bladder filling phase, normally in the filling phase, the detrusor should remain relaxed. But in this case, there will be detrusor overactivity or contraction. That is the diagnosis of basically overactive bladder syndrome. That means this bladder, which should remain relaxed, contracts during the filling phase. That's how we make the diagnosis. Now, why to treat? Any physical, social, sexual, psychological, and occupational impact is there of the condition, and is often associated with comorbidities such as sleep disturbance and all. If someone is getting up 5-6 times in the night, you can imagine how she will not be fresh in the morning, and she will be tired whole day. Then depression and poor quality of life will be there. So almost 32% patient had these symptoms. They felt depressed and all, and they can't sleep well. And then another important, because many of these patients are elderly, so they're also at an increased risk of falls and fractures from rushing to the toilet. Sometimes the patient rushes, and so it's very important that in the washroom of these patients, we should have some rail to hold, and the rugs should be there, and the water should not be there on the floor. Otherwise, these patients can fall. So that is also important. Now, management is usually non-surgical, And surgical treatment is very rarely done for overactive bladder syndrome. Just to complete the list, we are using it. So mainly these are lifestyle changes, bladder training, drugs, and very rarely we need to go for surgical treatment, which I'll be discussing. So first line therapy is always behavioral therapy. And in this case, behavioral therapy we'll be discussing like lifestyle changes, reducing weight and exercise, etc. We'll discuss. Second line are antimuscarinic drugs or beta-3 agonist. And then third line intradetular botulinum toxin injection, PTNS, SNS, or rarely surgical treatment as a last resort. So usually we do the lifestyle changes. That means weight reduction. If the patient is obese, basically there is abdominal wall weight also that all presses on the bladder. So weight reduction of 4 5 kg or 6 months is very useful for this patient. Otherwise, also that will be good for her knees, for her hips, etc. And she'll feel more confident. Then she should avoid caffeine and smoking. This is important. We need to ask the patient what is making her to pass urine or what is making her urgency. Like I had a friend, he after drinking 1 cup of coffee, he was a male basically. He had so much urge incontinence that he had to go to the washroom 7-8 times. Some patient have with coke, some patient have with berries. So like that, everyone has to find out their this thing. But definitely caffeine, tea, smoking, coke, etc. They are things. So we should avoid those foods. But we can drink water, but not in excess. And we can drink like coconut water or some juices. They can be good. Then physical therapy or Arnold Kegel's exercise are very important. But in this case, you need to train the patient, preferably by physiotherapy. I mean, it's a good idea to have a regular and dedicated physiotherapist in your clinic if you are doing urogyne. So they can spend like say half an hour to 45 minutes with the patient. They can teach them all these things. Otherwise, as a gynecologist also, we can also teach them. Patient can try to pass urine and hold on to it. She can try to pass motion, hold on to it. She can put a pillow between 2 thighs and contact it. So she need to do it 15 minutes in the morning, 15 minutes in the evening. So exercise are good for health. They cost nothing. That's what I tell my patient. But minimum give it at least 12 weeks, 3 months before saying that they did not work. And they will definitely have some benefit of this patient. We can use biofeedback and electrical stimulation for additional benefit, but not mandatory. And then bladder training will be discussing. So this are the, and of course, same thing, avoid drinking too much of tea, water, and, only moderate volume of fluid, 1.8 to 2 liter. Empty your bladder before going to sleep. Always empty your bladder completely. Empty your bladder before and after intercourse. Reduce your caffeine intake. Drink bladder-friendly fluids and avoid going to the bathroom just in case. Many times we just have nothing else to do to go to the washroom. Don't do that. Let the bladder has its capacity. And this is bladder training or retraining. In this case, basically patient passes urine at regular time by clock. Simply, this I got a lot of material on this, but just in the beginning, like suppose patient is getting up at 6 o'clock to 6 o'clock, and we can try to hold it like 8 o'clock. So first week 2 hours. Next week 2 hours 50 minutes, next week 2.5 hours, then quarter to 3 and 3 hours like that. So every week she increases the time, and along with she's doing other things also, like she's doing pelvic floor exercises, she's drinking less tea, coffee, and and we are giving some medication also to the patient like that. So Kegel exercise we have already done. So minimum, there is it's a first line conservative management, and there is a scientific evidence that they help. Cochrane database also says. So minimum 3 months, 12 weeks is required before saying they have not worked. And then biofeedback is in addition to Kegel exercise, so that patient is contacting right muscle, but the machine costs about 8 to 10 lakh rupees. But not that you have to have it, but it will, with this patient will contact the right muscle. That's the advantage of biofeedback. Same way, electrical stimulation also, that it strengthens the muscle in the lower pelvis. Electrodes are temporarily placed in the vagina or rectum to stimulate nearby muscle. So this is useful. So same thing, basically, all these biofeedback, electrical stimulation, they are augmenting basically Kegel's exercise only. Then most patients will require a medical therapy, and usually we have traditionally given anticholinergic drugs, the therapy with they have inhibitory effect on sphincter, and we tricyclic antidepressant like imipramine were popular in the past, but not anymore. But still, imipramine may be a good drug for patients of nocturnal anuresis, especially adolescent girls. So 25 milligram can be given to these patients. Alpha agonists are not that much, but estrogen again by reversal of urogenital atrophy, but systematic estrogen not needed. But definitely the patient had got urogenital atrophy. So topical estrogen therapy in the form of Pavlon or any estriol cream, first week weekly, later on thrice weekly for 3 months can be tried. Then others like botulinum toxin intracycle injection of this can also be tried as a last resort. And so principles will be they decrease retrousal activity, increase bladder capacity. And commonly used drugs basically will inhibit it. And this is the mainstay of therapy. Basically, they inhibit bladder contraction through acetylcholine receptors. But they have a side effect in the form of dry mouth, constipation, some drowsiness and somnolence, blurred vision, dry mouth, especially elderly patient. And if given for long-term therapy, like if you are giving her for 3, 4, 5 years, then sometimes they can cause some this some basically neurological symptoms. So avoid using them in elderly age group for more than 2 years, or give under basically observation. So these are the, I mean, you can just remember 1 or 2 drugs, like I'm fond of using either deriphenacin or solifenacin. So deriphenacin is 7.5 milligram, usually once a day, but you can go up to double dose of that. Or solifenacin is equivalent 5 milligram, you can go up to 10 milligram once a day and give it for 3 months initially. Okay, that is important, but avoid these drugs in case of close angle glaucoma. Then beta 3 adrenergic agonist drugs are mirabegron. So that is 25 milligram initially, but you can go up to 50 milligram once orally, and that is works on the beta 3 adrenergic receptors basically. So those patients of cardiac disease, it's better to avoid mirabegron because that acts through the adrenergic receptors. But patients with narrow angle glaucoma or who have dry mouth, etc., then they are very useful for mirabegron. So in other words, for heart patient, use anticholinergic drug, and for side effects of anticholinergic drugs like or narrow angle glaucoma, then use mirabegron. And sometimes we can, if the patient has got no side effect and all, we can combine the two also. Like we started deriphenacin for 3 months. Along with, of course, these drugs are not alone. Drugs are augmenting pelvic floor exercises. They are augmenting, they are apart from that, they, they are, we are less tea, coffee, less water intake also there. So that is what we do. And really, botulinum toxin as a last resort, we can use basically 200 to 300 units. I attended like King's College training. So in this case, what you do basically, there is 1 ml of the botulinum toxin, you dilute it to 10 ml, and then we do cystoscopy, and along with cystoscopy, we give this injection at 10 places. So that means 1 ml. 1 ml we has been converted to 10 ml. So 1 ml at 1 point. So 10 points we give botulinum toxin. So that also is work, but only as a last resort. So we have, though most of these drugs, solifenacin, they work on M3 selective anticholinergic drugs. Imipramine, I told you, only for not a very good drug these days, but sometimes we can use it for nocturnal aneurysm in girls, So combination therapy can be used, and that. Okay, refractory cases, you need to do any post-void residual urine. Always look out, like in North India, this stone is a big problem. Sometimes there may be papilloma in the bladder. So those patients who are not responding to treatment, then you can do urodynamic study in them. Cystoscopy can be done. And sometimes upper tract study like renal ultrasound, CT, MRI. I had a patient who had basically stones in the renal. So that is also important. So mirabegron told you 25 to 50 milligram. It's a beta 3 receptor agonist, can be used for these patients. Surgical treatment as a last resort only, cystoscopy, injection of botulinum toxin. Augmented enterocystoplasty, that means this is operation in which bladder capacity is very much reduced, like after thimble bladder, after radiation cystitis. So there's some these surgeons or these people, they can use the piece of sigmoid colon or a piece of small intestine with this mesentery. They can augment the size of the bladder. But this is last resort. I have never done it, but just to complete the list. So to conclude, improved understanding of pathophysiology is important, and contribution of alternate neural receptors, better understanding of receptors is needed, and mechanism of action of antimuscarinic drug and side effects is important, and refer to urologist and surgical disease. So thank you very much. So just in nutshell, basically, a patient who has got urge to go to pass urine and in absence of UTI is urge incontinence or active bladder syndrome, and usually history taking examination is important, and then usually we ask them to do pelvic floor exercises, bladder training, less tea, coffee, and one of the drug like mirabegron or basically anticholinergic drug like deriphenacin or solifenacin, and then we assess these patients after 3 months. The treatment can be given up to 2 years, and then we give drug holiday to these patients. So most patients, 70-80% patients can be treated like. Thank you very much.
Thank you, sir, for a very elaborative talk. So the hall is open for discussion. I would like our esteemed chairpersons, Dr. Nita Thakrey ma'am and Dr. Poonam Yadav, to ask and for the concluding remarks.
Dr. J B Sharma, that was really wonderful talk. You covered every aspect of the topic, and it was, conveyed in a very simplified manner, especially the importance of history taking, and also what are the causative factors that you showed. And the best thing which I liked about it is that you told that there are social, physical, sexual, psychological, and occupational factors that are impacted by in these patients, and that is why we need to actually identify them and treat them, give them the help. They usually take it as a condition which happens with age, and they neglect themselves. And I think with a better understanding of the subject and how to treat it, for any gynecologist, it's easier to help them. Thank you so much, sir.
Thank you. Thank you. Thank you.
Good to see you after a
Yes.
long.
Thank you. Certainly. Certainly.
You've been
Hope
really
you are
busy.
fine, man.
Dr. Poonam.
Okay, thank you, sir. Sir, your talk was well elaborated, and it's just a presentation like a great teacher. Beside the medical treatment, you have also take great emphasis on the counseling and psychosocial aspect of the psychosocial health of a patient, especially in cases of overactive bladder syndrome or rest of the other bladder-related issues. All pharmacological and non-pharmacological treatment were well described. Thank you, sir, for your.
Sir, I have a
expert
question.
Yes,
You said about drug holiday. So how much drug holiday practically we can give, for how long they can continue sulfasalazine and all?
Yeah, madam, after 2 years, I give drug holiday for 3 to 6 months. And during this time, we hope that patient has lost 4-5 kg of weight. She has decreased tea, coffee, water intake. She has lost weight. And she has, her pelvic floor muscles have become better. So we hope those factors have taken over, and then we can give it. So we give it 3 to 6, but in my practical experience, that almost 50 to 60% patients are okay after that. So I assess them after 3 to 6 months again. But some patient, I ask them, you have seen life with both, with the drugs, without drugs, which was better? So 50% patients say, no, sir, we want to go back on the drugs. So you can do, but avoid after 65, 70 years of age, don't too much long therapy. There have been some neurocognitive dysfunction has been observed in the patient on long-term therapy. So just observe them.
What
But
is your
you can-
experience with mirabegron compared to sulfasalazine?
Mirabegron is highly effective, but just avoid in cardiac patients. I mean, just be cautious. It's not that absolutely contraindicated, but mirabegron is a very good drug. And I have about 10 to, in my practice, 60% patient of mine are on anticholinergic drugs, darifenacin or sulfasalazine. About 35 to 40% patients are on mirabegron. 10% patients are on both. The combination of the two. One option is you can increase the dose, like mirabegron can be increased to 50 milligram, but then the side effects tend to be more. Similarly, sulfasalazine from 5 you can go to 10 milligram. But other option is that, 5 milligram sulfasalazine with 25 mirabegron may be a better choice, because then the side effects will not be added up.
And sir,
Provided there are no contraindications.
in case of mixed incontinence,
Yes,
which we will treat first?
Yeah, in case of mixed incontinence, you had to ask the patient what is bothering her more. I mean, there will be one dominant symptom, if the urge incontinence is dominant, then we need to treat the urge incontinence first with darifenacin or mirabegron. Along with in those mixed incontinence patients, I tend to give them other things like, pelvic floor exercises, decreased tea, coffee intake, bladder training. Plus, I also give duloxetine, 20 milligram OD. So 20 milligram OD for 3 months with darifenacin or sulfasalazine, and then I assess the patient after 3 months. But if the patient has got mixed incontinence, but in spite of this treatment, but her main predominant symptom is stress incontinence, then I have done surgical treatment also, TOT, but don't do in the beginning only. Like after 3 to 6 months, I asked that patient. So by this time, her mirabegron or sulfasalazine has taken care of her urge incontinence, but she says that I'm troubled because this duloxetine is not very effective. I mean, treatment for stress incontinence is usually surgical. Medical treatment is not that effective, but treatment of OAB is essentially medical treatment. So whatever is bothering her more, we need to treat that first.
Thank you.
Thank you.
Thank you, sir, for your pearls of wisdom and sharing your experience with us.
It was a lovely, fabulous talk, Dr. J B Sharma. I think
Thank you, man. Thank you. Thanks for the opportunity.
Every word what you said, and really insightful about the drug therapy, when to give drug holiday. I think that was so lovely and well discussed. Thank you so much for joining, J B Sharma.
Thank you, man. Thank you.
Dr. Aparna also is waiting.
Yeah. So we are next moving on to the stress urinary incontinence talk by Dr. Aparna Hegde, madam. So for that, I would like to invite our chairpersons. We have Dr. Meenakshi Ahuja, who is a senior gynecologist at Fortis Hospital. I think I couldn't see her. We have Aruna Biradar with us. She is from Shri BM Patil Medical College. She is a professor at Vijaypura, Karnataka, and she has been awarded the Young Scientist Award at her university. So welcome, Dr. Aruna. And we have our esteemed Dr. Monika Gupta. She was also an active member of Foxy Medical Disorders Committee, and she is the chairperson of AOGD Urogyne Committee. Welcome, Dr. Monika. So our esteemed chairpersons who would like to introduce Dr. Aparna Hegde, madam. I think there is some poor connectivity, so I would like to introduce esteemed Dr. Aparna Hegde, madam. She is Associate Professor, Urogyne, Kama Hospital at Grant Medical College, Mumbai. And she is a consultant urogynecologist at Surya Hospital, Mumbai. She is a founder and director of a center at Delhi, Urogyne Center, and she's running centers at both Delhi as well as Mumbai. And she's chairperson and foundation of International Urogyne Assistant. She's editorial board member of International Urogyne Journal, and she's also member of International Urogyne Committee of Prolapse. And she's a senior visiting fellow at IIM Ahmedabad also. She has so many awards to her credit. So it is like Niti Aayog Award, MIT Elevate Award, Scholar Award, British Medical Journal South Asia Award for Maternal and Child Health Team, and Social Entrepreneur of the Year Award, Women Changemaker Award. She has been awarded Fellowship of Menopause Society of Sri Lanka. So over to Dr. Aparna, madam. Welcome you, ma'am.
Oh, thank you so much for having me, Komal. And it's so great to be in the presence of such stalwarts. Thank you for that. I go back many years with Niranjan and Komal, so it's good to be here. Yeah, so I'm going to talk about SUI, right? One second. Can you see my slides?
Yes.
Yeah. So Dr. J B Sharma has covered evaluation of patient of incontinence, right? So I'm not going to go there because I have paucity of time. I'm going to go on to the management of SUI. So you evaluated a patient well, and now you've gathered that the patient has SUI, right? Even in mixed incontinence, all I'm going to talk about will apply for a patient for the SUI component, right? So first, of course, is lifestyle and behavioral modification. So obviously weight loss, smoking has to be stopped. You need to treat chronic cough and constipation, right? Now, Dr. J B Sharma has spoken a lot about Kegel exercises and how it is very important to ensure the pelvic muscle strength increases for both kinds of incontinence. I'm going to park it for now. I'm going to cover this in greater detail as we go forward, right? And then fluid intake is also very important in SUI because a lot of women will drink a lot of water. So you should restrict the amount of fluids to 5 to 8 glasses of liquids a day. Less than 5 glasses would concentrate the urine and irritate the bladder, but more than 8 is not required. 1 glass being 230 ml. Right? And time voiding is extremely important. So as Dr. J B Sharma spoke about the bladder diary, I do a very thorough bladder diary. All my patients will fill a 3-day bladder diary. And you will find a lot of patients, especially doctors, you will see, because we are so used to postponing voiding, right? So, we'll void after 5 hours, 6 hours, and we're used to going at large volumes. We get our bladder used to holding large volumes. So when you see that a patient is holding very large volumes and leaking at large volumes, it's so important to impose time voiding, right? Make them go every 3 hours, even if they don't feel like going. And over time, bladder gets used to the idea of going early. And at the same time, when they have mixed incontinence, then after you do pelvic muscle training, you then help the patient to increase progressively the interval at which they void, right? So time voiding is very important even in SUI. Now, when it comes to medication, you have two medications, right? So all of us know about estrogen cream. So every patient in incontinence, especially who's in a woman who's menopausal, you have to give local estrogen cream for literally 6 months, right? Daily for 3 weeks and then twice a week for 6 months. And then duloxetine. So duloxetine is banned in many countries, especially in the United States, because of side effects. But duloxetine I use only for very short periods. It's like when a patient comes to you and then they want to postpone surgery or any therapy for a couple of months, or because their the child is exam going, or immediately after surgery, before the sling takes effect, you want to give duloxetine for a little while, right? So the way it acts is that it increases the amount of glutamate in the pudendal nerve ganglion. And that is excitatory for the pudendal nerve, and it increases the level of signaling of the external sphincter of the urethra. And that's how it helps in SUI. So duloxetine cannot be given long-term because the side effects are quite severe, right? So now how do we treat it, right? Now, before I go on to the main treatment, I'm just going to cover things available in the internationally. So you also get pessaries with knobs. I've used those, but not so easy to use for patients. Again, it's stopgap. So the regular pessaries, the ring pessary, incontinence pessary, dish pessaries, they have a knob. Can you see the knob here? And that knob will go beneath the urethra, and so it helps to occlude the leaking. Next thing, now this is the main part of the talk. I do very strong pelvic floor muscle training in my clinic. In fact, literally 50% of my patients don't require surgery because they respond only to pelvic muscle therapy. Now, how does it help in SUI? So we have two types of fibers in our pelvic floor. Type 1 are the long contraction fibers and type 2 are the short contraction fibers. So you will exercise and improve the strength of both of them, right? So when you improve the strength of type 1 fibers or the long contraction fibers, it is regular strength training. And so you improve the stiffness and structural support of the pelvic floor over time. But when you improve the strength of type 2 fibers, type 2 fibers are the quick contraction fibers, right? When you say 2-second hold, 2-second relax, that's a type 2 fibers. So what happens is over time, you will strengthen it over 3 to 4 months. And then you will teach the patient something called as bracing or performing the knack. What does it mean? It means that before any woman does any physical activity that leads to increase in abdominal pressure, like coughing, laughing, sneezing, etc., they have to consciously contract. So 2-second hold and then cough. So you consciously do it. And when you keep on doing it consciously, over time, it becomes a behavioral modification. So body automatically learns to contract before coughing, laughing, sneezing, etc. And it really works beautifully. It's called bracing or performing the knack. Now, both of these helps only after the muscles are strengthened. Now, how do you strengthen the muscles, right? So you do get something called vaginal cones. Now, what are vaginal cones? These are weighted cones, which you hold in the vagina and is used for strength training of the pelvic floor muscles. So the woman has to kind of hold that cone in the vagina for around 20 minutes a day, starting with lower weight and expanding progressively, the amount, increasing progressively the weight held. And the cones weigh from 20 to 150 grams. I don't really like it because patients are not really compliant, but it's available, right? Now, then you come to Kegel exercises, right? Now, Kegel exercises, all of us know what they are. They are voluntary inward and upward contraction or squeeze of pelvic floor. Now, the issue is that in literature, the number of contractions recommended have ranged from 8 to 12, 3 times a day to almost 200 contractions per day, duration from 4 seconds to 30 to 40 seconds, and duration of treatment from 1 week to 6 months, commonly 3 months. So generally, I would like a patient to be able to hold a contraction 10 seconds long and relax for 10 seconds, 10 times, right? That's what the strength of type 1 fibers I'm aiming for, right? But the problem with Kegel exercises is that 50% of patients cannot identify their muscles. And in fact, 27% of patients will do reverse Kegel. They will push when you're asking them to contract, right? And many times patients are just told verbally how to do Kegel. You actually have to examine and do modified Oxford score. One thing I need to add to what Dr. J B Sharma said about evaluation is, in every patient, I evaluate pelvic floor muscle strength. Put 2 fingers in the vagina, ask them to squeeze and evaluate the strength. There's a modified Oxford score. Based upon that, I can really understand whether a woman can even identify her muscles. When a woman can't identify the muscles, just telling them to do Kegel exercise won't work, right? So you need to use biofeedback. And what is biofeedback? Biofeedback is a simple tool where you put a probe in the vagina, and when the woman squeezes it, she can get a visual and auditory cue about how well she's squeezing, or is she really squeezing well or not. So you can actually show on the computer what to squeeze and take them over time on the course of improvement, right? So in my clinic, see, the thing is this: even if a woman can squeeze well, she may not have endurance. So it's not enough to just look at whether she can squeeze well. Also, you have to look at the endurance. So I evaluate that clearly. And if a woman does not have endurance, even if she can squeeze well, even they will go through biofeedback therapy, right? So what we do is that they will come for 15 sittings, 10 to 15 sittings. Every sitting, we will have biofeedback therapy and then electrical stimulation. So let me go through both of them, right? So what is biofeedback? There are multiple biofeedback techniques available. I'm just showing you one of the techniques I use in Mumbai, and there's another one in Delhi. So this is a maple biofeedback technique. So basically, don't go by the name, just understand the concept. So basically, the biofeedback probe will have a electrode, right? So you can see the yellow buttons, those are electrodes. You could have pressure electrode, or you could have electrical electrode, right? So basically, a pressure biofeedback, sorry, or electrical biofeedback. So either squeeze or actually an EMG is picked up when the muscle is contracted. So that is put in the vagina. And in this particular biofeedback system, I can actually get the muscle strength of all the individual muscles throughout the pelvic floor. 360 degrees. Can you see that? This is how I get it. Put the probe in the vagina or the anal canal and see the entire muscle grid strength. And I can actually compare it to standard, like other women who are normal in the same age group, right? So when you compare, there's a color coding we use, right? So if it is, it's comparable, it's white. If it's hyper contracted, it's red. Or if it's very weak, it's blue. So patient gets a visual cue also, like how is her muscle, right? Because it's a misnomer to think that every SUI patient has weak muscles. Sometimes one side is contracted, the other side is relaxed. Even that imbalance can cause leaking of urine, right? So what do we do? When they come to us, I will look at the rest EMG. Then I will take them through a series of maximal voluntary contraction. You can see the middle rung. It's 2 second hold, 2 second relax. These are like maximal contractions, type 2 fibers. I will do that 10 times. And then I will do the endurance contraction of the type 1 fibers, right? So basically, you look at this patient, I've been asking them to hold for 10 seconds, relax for 10 seconds. Relaxation between the contraction episodes are very, very important. Equal amount of relaxation. And you should also see how they're relaxing, because they're not relaxing well, that also is very bad. So what happens is when they come for every sitting, you will see, firstly, you will teach them with the probe how to contract the right muscle. And then she will see on the computer, because she's seeing this. She'll see on the computer how well she's contracting, how long she's holding. Then you give her homework based upon that. So for example, if a woman can only hold in your clinic 2 second hold, 2 second relax 2 times, then the homework will be go to the bathroom in the morning, come back, sit, do 4 second hold, 4 second relax 4 times. 2 second more than she could hold, 2 times more than she could hold, right? In front of you, right? So 2 seconds more, 2 times more. So 4 second hold, 4 second relax 4 times. Then you're going to give a half an hour break, and also then exercise the type 2 fibers. 2 second hold, 2 second relax 4 times, 3 times a day. So progressively, they'll come back to you. If they're exercising very well, then you can see that they can improve. In your clinic, then she's holding for longer. Suppose she's holding for 4 seconds in front of you next time. Then you will give her 6 second hold, 6 second relax 6 times. So every time you add 2 second more and 2 times more, right? And that way you build up to 10 second hold, 10 second relax 10 times, and half an hour break, 2 second hold, 2 second relax 10 times. And then you get a grid like this, right? So when all the contractions are measured in a particular sitting, I get a grid like this where I can actually evaluate, like in maximum MVC is in the middle grid, you can see the maximum voluntary contraction. So it's all blue here. So it's very weak even in maximum voluntary contraction. And if you see endurance, she's able to hold the middle fibers, right? On the right and the left. So I can, through the color coding, we can understand which muscles are improving over time. So see, I can look at the average EMG and the peak EMG, both of the maximum voluntary contraction and the endurance muscles, right? So, and on the left side is the rest. So basically, over time, we are seeing how the woman is improving, and it really, 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 really works. I can't begin to tell you how useful it is to do biofeedback therapy, electrical stimulation in our patients, of SUI, even overactive bladder, right? I'll give an example, right? This patient, first week when she came to me, if you look at the, EMG, I told her to contract, relax. She just couldn't identify the muscles. When we trained her and when she went back home and exercised, look at this. A week later, she could hold, right? And then over time, her amplitude of contraction will also increase. The strength will increase, right? So then when they come to you, you will take them through 10 seconds hold, 10 seconds relax 10 times to see the endurance and give them homework. And after that, you will also do electrical stimulation. Now, electrical stimulation is like a lazy man's Kegel. It's a technique for passive contraction in women who can't contract pelvic floor muscles voluntarily, right? And you can give that through either the vaginal or anal electrodes. And they help to, in motor excitement also, is analgesic, right? So basically, it's like a lazy man's Kegel, a probe in the vagina, and you're stimulating the muscles, right? And then I can stimulate different planes. I can decide which I want to stimulate more. If a muscle already contracted, I won't stimulate that. I would choose a muscle which are weak to stimulate. So there is ring stimulation, plate stimulation, right? And then you would use different frequencies. So in urgency incontinence, I use 12.5. If it's stress incontinence, I would use 50 or 100. If it's mixed incontinence, I would use 20 hertz. And these are on and off current, right? Strengthening current. You would do something different for women who can't pee. In those, you would do relaxation biofeedback. You'll be doing biofeedback to relax, and you do electrical stimulation, which is continuous because you want to tire off the muscles. So there are different frequencies and different systems used for different kinds of leaking of urine. Cochrane review, clearly, there's a recent review that's come off which says that first-line treatment, both SUI and OAB, is pelvic muscle training, and both biofeedback and electrical stimulation have been found to be superior to just pelvic muscle training and have been found to be superior to vaginal cones. There's a latest by Cochrane review that's come out, which is a review of reviews 2022, and it showed biofeedback electrical stimulation really, really good. So really, this is something that has to be practiced more. I do it very sincerely in both. We do it sincerely in our Delhi and Mumbai clinics both. Now, then comes surgical treatment, right? Now, when we do that, when conservative management has failed, you've kind of the remaining 50% in whom just the urgency biofeedback therapy is not work, or when you have intrinsic sphincter deficiency. Now, what is intrinsic sphincter deficiency, right? It is a condition where the sphincter is weak of the urethra. In those patients, you can't do pelvic muscle training alone. It is not going to be useful, it won't be enough. In those patients, ISD patients, intrinsic sphincter deficiency, you need surgical treatment, right? Or bulking agent injection. And if a woman is unable to comply with non-surgical therapy, right? So now let's look at surgical treatment. So because of paucity of time, I'm going to go through what should be done in which case, right? So just give you an idea of where what is applicable, because it's so important to choose the right surgical method, right? Because it's not like one size fits all. I know this kind of surgery, so that will be done in every patient. It doesn't work like that. So historically, how has it moved, right? Earlier there was anterior repair, but in which Kelly stitch was done, but 40% failure rates, Kelly stitch is not enough. So then it went on to autologous slings, right? There was the rectus fascia, fascia lata. Then came the retropubic bladder neck suspension operations, Bursch, open, right? And then came needle procedures. Needle procedures have gone out of vogue. Now nobody does needle procedures. Then came the synthetic slings, right? So instead of using autologous, people started using mesh. Then came the laparoscopic burst corpus suspension. Then came the modification synthetic slings, which is tension-free slings, the modern TVD, retropubic sling. And finally, according to some people, the pinnacle of it all is transobturator. Why? Because simple, it's efficacious, safe. But is that the case? Let's see whether you should be doing transobturator in everybody, or you should pick and choose in whom you're going to do which surgery, right? So let's go through every. So just listen to the take-home messages. Because of paucity of time, but these are extremely important take-home messages. When will you do which kind of surgery? Now let's come to Bursch. Now we all know what we do in Bursch. In Bursch, we suspend the bladder neck to the Cooper's ligament bilaterally, right? Now remember one very important thing. Never, never, never do Bursch when a woman has intrinsic sphincter deficiency, ISD. And ISD is a urodynamic diagnosis. In urodynamics, if I find that the maximal urethral closure pressure is, less than 20 centimeter water, or the Valsalva leak point pressures are low, right? Let's not go into technicalities of it, but just understand when the woman has low Valsalva leak point pressure and maximal urethral closure pressure, which means that she's got intrinsic sphincter deficiency, the sphincter itself is weak within the urethra, never do Bursch. Why? Because what does Bursch do? It pulls the bladder neck into the abdomen and keeps it open. Right? So in an ISD patient, they will leak more. I have seen patients who have undergone Bursch or even sacrocorpoplexy, and the bladder neck has been pulled up and kept open and they're leaking like a tap. So never do that. Another problem with Bursch corpus suspension is that there's an increased chance of enterocele formation because it pulls the bladder neck anteriorly. Right? So a very recent meta-analysis clearly shown that's inferior to retropubic slings. Okay? You can do Bursch in, when you're doing, it's a regular hypermobility associated with SUI, where the supported urethra is weak, the sphincter is normal. You're anyway doing hysterectomy laparoscopically in that patient, then you can combine that with the Bursch, right? But never do it in ISD patients. One big take-home message. Then comes the retropubic bladder neck sling, which is the or the pubovaginal sling. Now, what does it mean, right? After Bursch came the autologous fascia, and when the autologous fascia came into the picture, they were put to the bladder neck. Okay, it's also called as pubovaginal sling. Now, these are good slings to put in those with ISD. Okay. Now, the thing about retropubic slings are the meshes, the autologous fascia is, it's non-deformable, right? It's not deformable because it's tissue, right? So you will put it at the bladder neck and you will put it a little tighter because ISD patients, you want a little bit of obstruction. These are women in whom the sphincter is weak. So you want a little bit of obstruction, right? So you will put it at the bladder neck. You will do that in patients who've got ISD or they have failed previous incontinence procedure. And if you do it correctly, the overall long-term cure rate can be around 85 to 90%. Now, pubovaginal slings have been found to be as effective as retropubic slings, but they say that there are more storage symptoms. Now, what do they say? They say that if you put a pubovaginal sling, there's more chance of obstruction. But what I find in my own practice is that if you put in the right patient, those patients who got very weak sphincter, those patients you anyway have to put it tight so they don't have obstruction symptoms. You will have more obstruction patients if you have put it too tight in a patient who does not have sphincter issues. So over time, you learn how much tight to put, right? So bladder neck slings are the autologous fascia slings, right? So clearly, if you look at the evidence, European guidelines clearly state that autologous fascial sling is more effective than Burch-Corpus suspension, okay? But they are associated with more voiding dysfunction issues, right? But you have to choose the patient correctly. Don't put in an autologous fascia tight in those who don't need it to be tight, right? Next comes the TBT and the TOT. Now let's not call it TBT and TOT. Let's call it retropubic and transobturator. Why? Because multiple companies have come out with different names. So TBT of J&J is retropubic and TBT-O of J&J is transobturator. So it's confusing. So we'll not talk about TBT and TBT-TOT. We'll talk about retropubic and transobturator slings, okay? Now, both the retropubic and transobturator sling lie mid-urethral. And what do? They are actually supplanting the support given by the pubourethral ligament, right, at the mid part of the urethra. You're going to put the two slings tension-free, meaning you're going to leave a little bit of space between the urethra and the sling. You're going to be tension-free. Why is that? Because you're not supposed to cause obstruction at rest. Only when the patient laughs, coughs, sneezes, or does any physical activity that leads to increased abdominal pressure, you want the sling to cause dynamic compression at the mid-urethra. Now, it is very, very clear. Take home message. After 8 years, it has been clearly shown that retropubic is more durable than transobturator. Okay, so retropubic has been found to have higher objective patient-reported cure rates at 8-year point. Please understand. Okay, very clear. So if I have a younger woman, I will put in a retropubic sling. I will not put in a transobturator because the evidence is not available that long, right? Retropubic has long-term evidence, right? So there's 11-year evidence for retropubic. There's 17-year evidence. Same group of women were followed up for 17 years, 90 women, and it's the status high, 90% objectively continent. But one thing I want to ask you, when you look at all the papers, they'll keep saying retropubic is equivalent to transobturator. That is what you'll read in the conclusion. Plus, please understand, all these papers have excluded mixed incontinence and ISD. So please read the fine print. Most papers exclude mixed incontinence ISD. When you exclude mixed incontinence ISD, retropubic is equivalent to transobturator. Even in the long-term study for retropubic, they've excluded ISD and mixed incontinence. So that's the thing. In ISD, which is a very special category of patients, which we see a lot in our clinic, remember, transobturator should never be put. The reoperation rates are very high. It's almost double. Okay, so please understand, in ISD patients, intrinsic sphincter deficiency patients, always do a retropubic sling and not a transobturator sling. Now, transobturator is of two types, outside in and inside out. If I have time, I would have shown you surgeries, but lack of time, right? So I have 10 minutes more, but I will try and show you surgeries also. Outside in, inside out, right? Now, outside in and inside out are equivalent in results. But when we talk about outside in, I like them better than inside out. Why is that? Now, in transobturator sling, you go in outside in, you go from the groin and come out through the vagina. That means you are having the groin point of entry under control. In inside out, you're going from the vagina, coming out from the groin. Now in that, I don't have the groin point of exit under my control, that much. So groin pain is a huge issue. Okay, when you use meshes for transoperative sling, which go from end to end, all the way mesh, you can have groin pain. And if you have a patient of groin pain, they'll be a friend for life. 10 to 15% of patients can have groin pain. Most of them recover, but there'll be 2 to 3% will be really a friend for life, right? Groin pain can be really bad, and it's worse in patients who have got inside out, because where come out in the groin is not under your control. Okay, that's one thing to remember. And mesh-related complications are higher in transoperative than retropubic, and dyspareunia, so sexual pain is more in transoperative, obviously, because the mesh is lying horizontally. Right? So in garden variety SUI, both approaches are similar, but in ISD, I will do retropubic. Right? Now they say complication of retropubic is much more, because you will go through the bladder, right? See, I mean, as Urogyn, we're very used to perforating the bladder. I mean, you can perforate the bladder twice and nothing will go wrong, right? I didn't mean while doing this, we used to opening the bladder. So bladder is actually a very forgiving organ, right? It's an extremely forgiving organ, even more forgiving than our gynec organs. Seriously. So if you perforate even twice, it's fine, right? If you perforate 3 times, it's not fine. But if you follow the right technique, the perforation levels actually go lower. The thing about retropubic is, and transoperative is, that it's easy to put in a transoperator. Removal of a transoperator is very, very hard. Why is that? Because if you look at where the transoperator goes, if you see the direction of transoperator, look at where it goes, right? It's coming out from the adductor medius, brevis. This is a part of the body none of us knows anything about. The orthopedic people don't know, the urologists don't know, the urogynes don't know, the gynecs don't know. So removing a transoperative sling is harder. Why? Because when you go to the transoperative sling, it's easy to remove the vaginal part, but the mesh tends to fuse to the pubic bone. So to remove the thigh part, you would actually go to the thigh. I have a case in August actually. There's a patient in whom a regular Indian-made mesh was put in. Be very, very careful what kind of mesh you're using, because we're using a microporous mesh, and some Indian-made meshes are microporous. What will happen is that infection can go through, but lymphocytes and macrophages will not be able to go through the pores. Bacteria can go through, but the lymphocytes and macrophages cannot go through the pores. And then there can be encapsulation of the infection. So I've got a patient who somebody else had put a sling 6 months ago, and the entire thing is encapsulated and infected. I have to remove the mesh in August. It's a nightmare. I'm looking forward to. I've already done 3 cases like this, and it's not easy. Right? So please remember, putting in a transoperator is easy, removing is not that easy. Whereas retropubic area, we all know, we all do Bursch. So, that area we are familiar with, the retropubic space. Okay. So do you do TOT in all patients? No, you have to individualize. So younger women, ISD women, I will do retropubic. Older women, I may consider transoperator. If I'm doing concomitant prolapse surgery with sling surgery, I would rather do retropubic, because my ultrasound work has clearly shown retropubic sling tends to stay in place more often, right? So always choose the right patient. Both slings will work beautifully for you, right? Now, how about the new mini slings? Be very, very careful. The mini slings have not really come to Indian market that much. But remember that, what do you mean by single incision slings? Now, these are slings which are if you look at TOT, transoperator, they have 2 incision points in the vagina and the groin. Whereas single incision slings have only 1 incision in the vagina, and the other part hitches in the operative membrane. Now, the issue is that all of these slings have different fixation mechanisms. So just because there's evidence for one fixation mechanism does not mean that there's an evidence for other fixation mechanism. Be careful, right? Now, there's another sling called TVT Abrivo. It's a very good one. TVT Abrivo improves upon transoperative sling. How? TVT Abrivo actually is a transoperative sling. But the only difference is that because there's a groin pain chance, what they have done is that they have kept the mesh smaller, shorter, and the ends are proline stitches. So what happens is only proline stitches go through the operative membrane and operative muscle. And so pain is lesser, right? So the success rates are pretty high. So you can use TVT Abrivo instead of transoperative tape, which is going to mesh all the way through. Yeah. Now laser, lastly, I'm going to finishing last points. Laser is not useful. There's evidence coming out that even in moderate SUI, it's not useful. And in mild and moderate SUI, my biofeedback works beautifully. So why would I do laser, right? So be very careful about using laser. It's industry driven. Biofeedback is absolutely non-invasive, whereas laser is invasive. I have seen in US in my training, patient coming with indiscriminate laser being used and vaginal stenosis because of that. So be very careful, right? So only when evidence comes out saying it's great, then you can go ahead and use it. FDA has come out saying that be careful unsubstantiated advertising. Okay, mixed incontinence, again, reoperation rates are higher in transsubstantiated growth. Okay. So be careful. In older women, I might put transsubstantiated. Younger women, I would rather put retropubic. Okay. Recurrent SUI, do not put transsubstantiated. Either put retropubic or bladder neck sling, the pubovaginal sling I spoke to you about. Okay. So do we have time to show videos or no time? Can I show videos?
Yes, ma'am. Yeah, ma'am. We would love to hear.
Yeah. So basically, I've got 2 videos. So just to show you, I'm showing you a simple outside in video of a transsubstantiated sling. Okay, now see, outside in. So basically, how do you do the marking? You have the patient lithotomy, and then you have the when the patient lithotomy, you will feel the adductor longus. Then next time lithotomy, tendon, you'll feel a very tough tendon there. Now mark on the groin fold just beneath where the tendon ends. See my finger there. It's basically where the groin tendon ended. You can feel that give way. Tendon is very tough, right? Now this is a point of entry, right? But I will not enter there because if you enter in the groin fold, it can be painful for the patient. So you'll take an incision medial to the groin fold. Can you see the line there? That's where you enter, and then you go laterally after you've gone through the skin. Okay. So basically, and I'm showing you the earlier monarch, okay, when the incisions were long. So, okay, this is how it goes. You have the obturator canal, which is superolateral. You want to avoid that. That's why the position I showed you is very safe. That's a safe entry zone of monarch or any outside in mesh. All of them have followed the monarch sling, though monarch is no more available in the market. Okay. So what do? We're going to mark out adductor longus. Okay. And this is the direction, right? And literally it's at the level of clitoris, but I would not follow the clitoris. We're just showing you that it's almost at the level of clitoris, but that's the point where the adductor longus tendon is ended. Okay. And that's a groin fold. Okay. We're just marking out. But you can feel the give way. Okay. This is your point of entry. Okay. And that's the direction of your needles. Okay. Okay. And then we're going to hold the vestigial folds. Now here the incision is very big. We don't take such big incisions now. It's evolved over time, right? So you would take mid-urethral. The incision in transport is a little bigger than the retropubic, but I would not go beyond 1.6 centimeters. Here you almost say 2 centimeters. Never go big incision because the sling tends to shift then. Okay, but it's evolved over time. Here there's more finger resection. Now we only do sharp dissection with mesenbom or stilis. See, now I told you, right? You don't go through the groin fold. You'll go medial to the groin fold. So we've put in lidocaine adrenaline there. Then take an incision. As I said, don't take as big an incision I'm going to show you here. It's mid-urethral. Earlier, we would do very big. This is the time when monarch actually came. This is from Cleveland Clinic, and that time monarch had just been. We were actually, testing out monarch at that point in time. Right? You dissect. You will carry forth the sharp dissection all the way to pubic membrane, perineal membrane. Don't do finger dissection, though we're going to show you finger dissection here. Okay. But remember, the incision in transplanted is always bigger than the one in retropubic. And you're going to go all the way to the perineal membrane, either side. I'm going to fast forward it a little bit. In a short video. Okay. And then you put your finger there, and then you look at the way we're going to hold her, and you can feel the pubic bone on either side. Okay, now see now incision is medial to the groin fold marking. because you don't want to go through the groin fold. Otherwise, it'll be painful for the patient. Mesh can't go through the groin fold because it's a fold, right? Painful. So go medial to it. And then this is the direction of the needles. All needles outside in will go in this direction. Okay. And all of them have copied Monarch, but be careful. Some of them have larger curves. So be careful. So then when you go inside, see, this is the way. Look at this. This is very important. Okay. You got a finger in the vagina and your thumb will be on the needle. And you're going to go in perpendicularly in till you hear 2 clicks. You're going to go to the obturator membrane muscle and then turn. Okay. So you can actually see the clicks. Okay. Now just see how it goes. Okay. You will go perpendicularly in, just see how it goes. Okay. Now they push it in perpendicularly and you will feel 2 clicks. See this. Okay. See this. Go through the skin and then go laterally. Okay. See this. Go through the skin and then go laterally. See, laterally and then through the groin fold beneath the skin. 2 clicks you will hear. You will feel the give way. See. One more and then turn. You could see the give way, right? And then when you turn, it comes beautifully through the vaginal incision. Right? And then different meshes have different fixation mechanisms. And then you bring it out. And you go in the same curve as you bring it out. Okay? You pull it out in the same direction. Same thing you'll do on the other side. Okay? And then don't worry about these markings. All of these meshes come with their own techniques. What you need to know is the principles of doing this, right? So basically, Monarch came with this play point where you cut out. And remember one thing, Monarch had a plastic around it. Many of the meshes don't have plastic. When they don't have plastic, be careful about the friability. They should not be traumatic. Many Indian meshes are traumatic. They shear through the tissue. I use a CL Medical eye stop. Which is absolutely, which is not covered plastic, but which is very nice, fine material, doesn't shear the tissue. Okay. Okay. Now, once we've done that, you will hold the plastic where plastic is available and then tension it. So, okay, but how to tension it? Right now, tension should be perpendicular. Okay. It should not be parallel to the urethra. Okay. Very importantly, because tension free. And now tensioning now, here you're going to see scissor being used. I like to use Kelly's. Use one thing that you're comfortable with. We used to use scissor earlier, now we do Kelly's, and now we go all the way to the break of the scissor. Okay. Don't use it only the tip. In this patient, we want to make it tighter, but we don't want to make it normally tighter. Go to the break of the instrument. Okay. Put the instrument perpendicularly down. But look at the direction of the instrument. It's perpendicularly down. Right? And go through the break. Okay. Go through here. And then tighten pull on both sides so that the sling is approximately tension free. And then remove the plastic. Okay. And then you will close the incision with 20 vital sutures interrupted. Okay. And then cut the mesh. Okay. Do I have time to show TVT, retropubic? I don't think so. It's a big lecture, so I can't hear you, Ruchika.
Okay, TVT also, ma'am, you show, please.
Okay.
That
so
the
I'm
lecture
going to show
will be
you
complete.
something that I use. So when I was in Cleveland Clinic, we had the eye stop mesh there. It is a French-made mesh, excellent mesh, excellent. Now the J&J one is not available. So luckily, when I was coming back from Cleveland Clinic, I told them you have to come to India, and they are in India, and it's cheaper. It's the best mesh. The good thing about the eye stop mesh is that's non-deformable. See, if you look at multiple meshes, you should go back and see when you pull it. Okay, if it gets pulled and stays pulled, it's not good. You want to use a non-deformable mesh, because when you use a non-deformable mesh, what happens is it remains tensioned how much you tension. If a mesh tends to get distorted, then it can become tight over time, right? So be careful. Okay, now the eye stop mesh, right? You see, look at the eye stop mesh, doesn't have plastic, but look at the pore size, so important. And look at the edge. The edge is very nice. It's not friable. It's not traumatic. And the pore size is very good. You want the pore size to be good enough that even if infection goes through, bacteria go through, lymphocyte macrophages can go through the pore, right? So always use a polypropylene type 1 macroporous mesh. Very, 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 very important. I'm going to show you a case where I'm doing both. I'm going to show bladder neck sling. And because I've already shown you mid-urethral tensioning, right? So the tensioning in retropubic is similar. Okay, when you do it retropubically. But I'm going to show you how we do it in bladder neck here. Okay, so that it combines into one. But remember, though I'm showing you bladder neck here, I put in patients who don't have even with ISD, I put in mid-rectal. I tend to understand which to put where, but mostly normal hypermobile urethra, you would put the mid-urethra, retropubic sling, okay? And tension, like I showed you in the TOT case. Tensioning is the same, whether TOT or retropubic, okay? Now, since bladder neck, again, infiltration, I'm going to go fast. Infiltrate nicely, okay? Incision, this incision is more the bladder neck, right? Because, and then you will do the same thing I showed you, right? And this is a small, so around 1.6 centimeters for the incision I take, okay? And then you will incise, you will dissect till the perineal membrane, which I showed you already how to dissect. Okay, it's all the way to the perineal membrane. Okay, we normally take 1.6, and then in bladder neck slings, there's a tendency to, there's a technique of, I mean, earlier there was by convention, you put a stitch of bladder neck, right? But you don't need to. You can feel the bladder neck. Okay, what I'm showing you more importantly is the direction. How will you go? Okay, now see the thing. This is how it's going to go. Okay, now you can, I don't have time. There are multiple techniques, but you understand this particular technique. You're going to put your finger in the incision and go with, go in this towards same side shoulder. And once you cross the perineal membrane, drop it. Okay, and you'll come out through marking 2 cm lateral to the midline, 2 finger lateral to midline. Okay, just at the level where the pubic bone ends. Okay, so basically this is going to be 2 finger lateral to the midline, just above the pubic bone. Okay, and once you do that, you're going to do scopy. Why are you going to do scopy? Because you want to be sure you have not perforated. Like I said, I mean, when you do it correctly, when you go towards the same side shoulder and drop and come out, it comes out really nicely through the marking and you don't perforate. Even if you perforate once or twice, it's fine. Just that you have to catheterize for a little longer. I found it even if you perforate once and the catheter remains for only 24 hours, it's fine. That is such a forgiving organ. Okay, so you're going to do scopy nicely to see whether any perforation. If there's no perforation, then you will attach the mesh and you tension. And tension is going to be like I showed you. I'm going to rush to the tree because there's another technique of doing retropubic also. Some other time I will teach you that. But for now, this is okay. Okay, then tensioning. Okay, now the degree of tensioning depends upon the degree of sphincter deficiency, right? So when there's a severe ISD, we tension really tight. Okay, one last thing before we end is that one last thing I want to say is it's a misnomer that you need scopy in transubtator. Please always end a transubtator surgery with scopy because you could perforate a urethra. Okay, be careful. Always do scopy whether you're doing transubtator or okay? Yeah, bye for now. Sorry.
Thank you, Dr. Aparna Hegde. You are such a good teacher. I would like to invite comments from the Meenakshi Ahuja ma'am and Komal ma'am. Dr. Aruna, are you there?
Yeah, ma'am, I'm here.
Yeah. So concluding remarks.
Yes, I think Aparna's talk was just wonderful with practical procedures and you have told us the tips and tricks how to go about and do it successfully. So it was lovely, Aparna. Thank you so much. You are the master in the field, and whenever you talk, we know it is the right way to do. So thank you. It was great. I saw Dr. Meenakshi Ahuja also. She was there, joined in. So Dr. Aruna.
Yes, ma'am. Good evening, ma'am.
Good evening.
All.
What about your comments?
Yeah, it was very sweet. Even though lengthy, it was very knowledgeable talk, ma'am. Sorry. I just want to ask one thing. Do you prefer any particular surgeries, especially in obese patients, ma'am?
No, so obese, no. No matter how obese they are, that particular area, the obesity doesn't really come in the way, especially in retropubic slings.
Yes.
Okay. I will base it on the degree of sphincter deficiency. I will base it upon one more thing. I didn't have time to show it, but I do a lot of ultrasound work, right? So I can actually see where the mesh is lying after I finish the sling surgery. I mean, after like post-op and all, right? So in the mesh in transabdominal tends to shift proximally because of their weight lies. You know, it's like horizontal, right? It can shift proximal. I really want that the sling remains mid-urethral. So I'm very careful that if I don't have the markings correctly, right, I would rather do retropubic than the transabdominal one. But it doesn't matter. Older women, you can put a transabdominal sling.
Okay.
But be careful, rule out ISD. Intrinsic
Yes,
never put TOT. Yeah.
Okay.
I just want to
one more thing, ma'am. Do you prefer combining these surgeries with any other surgeries, or it's only sling surgery or whatever surgeries?
No. I will look for in prolapse patients. I always look out for occult SUI. Often prolapse patients have hidden SUI. Why? Because prolapse kinks the urethra. Some patients will come with SUI along with prolapse. I will do concomitant surgery. But if they come with prolapse alone and no leaking history, I will actually look out for occult SUI because sometimes the prolapse kinks the urethra. You can't see it. I will elicit it. And then I'll give the choice to the woman. Do you want to do prolapse surgery alone or do you want to do it concomitantly with SUI surgery? Right? And anyway, both prolapse and SUI need to do biofeedback therapy. That is universal for me. But when I do SUI and prolapse surgery, I will put in the sling first, but not tension it. I will do the prolapse surgery, suspend the apex, and then tension the sling. You know, because I don't want to get this location distorted. So be very careful. I like to do retropubic in prolapse surgeries because of the fact that retropubic tends to stay in place more often. I am very anal about putting it mid-urethral.
Okay. Thank you so much, ma'am. Thank you.
And is there any role of drug in case of SUI? You have just mentioned the duloxetine.
So see, duloxetine can be given and it's helpful couple of months. I don't like to give it for longer. It doesn't have side effects. It works by increasing glutamate. There's no other drugs. Yes, you can give a little bit of amitriptyline in patients with mixed incontinence because amitriptyline acts on the bladder neck. It also acts on the bladder. So it's got some role in mixed incontinence. But overall, other than that, other than SNRIs, there's no drugs out there, right, on SUI. Even on clean, of course. Yeah.
Okay, thank you, madam. So it was a very, very informative lecture. So we now move on to the next session. And Dr. Komal Chavan is going to speak on urinary tract infections in pregnancy. So we have Dr. Anupam Gupta. He is the past Vice President of FOXI and he is also currently the President of ISOPARB of Agra. Welcome, sir. Next, we have Dr. Anita Sabharwal, madam, with us. She is the recipient of FOXI Champion, Wonder FOXI and Dhira Award. And she is the President of South Gynecologist Forum of Delhi. And she was also the chairperson of ISCCP Public Awareness Committee and past chairperson Adolescent Health Committee and executive of NARCHI. So we have so much esteemed teachers with us. Welcome, Dr. Anita Sabharwal, madam. We have P Pallavee with us. She is professor and head, Mahatma Gandhi Medical College and Research Institute, Sri Balaji Vidyapeeth, Pondicherry. And she is a great teacher. So welcome, Dr. P Pallavee. She is also a research fellow. So I invite Anita Sabharwal, madam, to kindly introduce Dr. Komal, madam, for her talk.
Thank you, Dr. Ruchika, for the wonderful introduction. And especially now you've given me the very fine duty to introduce Dr. Niranjan Chavan, because I know her so well, you know. I initially knew them from our Facebook. I knew her husband first, and then she's such a wonderful person she is. And, you know, actions speak louder than words, because gaining knowledge is first step to wisdom, but sharing knowledge is the first step to humanity. And also we can say sharing knowledge is also the most fundamental act of friendship, because you give something without losing something. So this is what she's been doing for the past, I can see, so many years now. So she's the medical director, Chavan Maternity and Nursing Home, and a very, very well decorated person with lot of, I think, she has credits to her. And she's the national trainer for FOXI Dhira, national expert for FOXI UNICEF, and member managing council of MOGS. and senior consultant DNB teacher also. So she's a teacher as well as a very good orator, and she's going to speak on a very, very common and very important subject, that is UTI, which all of us must learn from her. So I request Dr. Komal to kindly go on with a wonderful lecture.
Thank you so much, Dr. Anita ji. I think I'm really fond of her. She brings like the flowers and the beauty. So when we see her, we always feel very cool and de-stresses us. So that is how she is, and really like to see her updates. And whenever she is there, it is always a happy mood around. So thank you, Anita ji, and thank you. I think Dr. Anupam Gupta sir also had joined in between. I saw him, and Dr. Pallavee. So all the chairpersons much, and we had lovely talks by Aparna, and we had lovely talks by our J B Sharma. I think both the talks were so good and very, very apt, and they were so practical, these talks. You know, the talk which Dr. J B Sharma and Aparna, it was more of a surgical aspects. And what I am going to talk more is about a common condition we see day in and day out in our OPD. We have so many patients who are coming with this complaint. They come with urinary tract infection, maybe a very common thing in our OPD. And we really need to know when we try to investigate, some patients get recurrent infections. And that is how we always feel what we should do. So I felt the episode of Urogynecology will not end if we don't complete the management of UTI, though being very common but very practical. And that was the idea of introducing this short talk. And thank you for your kind introduction. I'll go with the quote: the secret of getting ahead is getting started. And with that, we start with our today's topic about the UTI. And what are the factors which affect? These are what we are going to talk: the socioeconomic burden, the prevalence, what is infection, colonization, contamination, what is uncomplicated, what is complicated, what is persistent and recurrent UTI, asymptomatic bacteria, whether to treat, what to do, imaging, and reference. So this is the purview of today's talk. And UTI, as we all know, it is a microbial pathogen within the urinary tract, whether it is urethra, bladder, or kidney. And most common UTI, the infection is bladder. So it is a cystitis, wherein we see a frequency, urgency, dysuria, hematuria, and suprapubic pain. Usually an ascending variety of infection, what we see in our female patients because of from the infection from perianal and perivaginal region. And we always say that urinary tract infections are more common in women than in male. Shorter urethra opens near to vagina. Pregnancy is a condition which reduces the immunity. Chances of UTI in pregnancy are high. There is easy contamination, which we spoke, and the hormonal changes seen at time cycle. So definitely we have an increased load of UTI cases than the male patients which come to the OPD. So most common is infection, almost 50 to 60% will experience this infection. And it becomes recurrent if there are 2 episodes in 6 months or more than 3 in the past 12 months. So this is very, very important to know whether it is recurrent or no. So asymptomatic infection is when a bacteria or fungus strain can be isolated in appropriate quantity, but the patient may be not having any symptom about UTI. So such cases, if it is there normally, it is not actually required to treat them aggressively, where we need to asymptomatic bacteriuria. Why? Because if left untreated, it may progress to lower urinary tract, can reach the kidneys, cause pyelonephritis, and affect the pregnant mother, and the pregnancy can get complicated. There can be higher incidence even of low birth weight. So everything in the pregnancy, there can be fever, and this is going to further complicate, and a morbidity in the pregnancy will increase. So definitely we need to look for the signs in a UTI. They are the fever, more than 100, increased frequency, urination,
dysuria, suprapubic pain, which we said, and pyuria. And the classical test which we do is a microscopy to know, but a culture and a sensitivity is really required. The midstream urine sample needs to be taken in a container, sent for culture, and if culture is positive, then do a sensitivity test. And believe me, we need to insist on a patient that they collect the midstream sample without contaminating the vagina, the surrounding skin, because that is going to introduce and get a contaminated sample. So actually, when do you do culture? Because you feel that a patient is immunocompromised or pregnancy, if there is a UTI, get a culture done. Recent exposure to antibiotics, we have already given antibiotics, patient has not got benefited. Recurrent infection, advanced age, or there is a catheterization or any instrumentation. Definitely don't just empirically do a culture and teach culture specific. So on culture, what we see, if you see more than 1,000 colony forming unit, it is usually goes in favor of cystitis. 10,000 it goes in pyelonephritis, and when we see more than 1 lakh, it is an asymptomatic bacteriuria. So this is how we will see, and I try to isolate and culture the bacteria which is there. So we need to, when we're trying to report the urine sample, we need to be familiar with these terms: contamination. That is, the organisms are introduced while collecting urine. So this is not, it's a contaminated sample. So you discard it and ask for a fresh sample. Here there are no health concerns. Then comes colonization. Organisms are present in the urine, but are causing no illness or symptom. It is kind of an asymptomatic infection. So here we need to just observe the patient. But infection is a combination of pathogens within the urinary symptoms with symptoms and inflammatory response. So this infection requires treatment. Then coming to the uncomplicated and complicated variety. Uncomplicated is a healthy patient. Anatomically, no problem. Functionally, no problem. Everything. So this is a healthy patient. But complicated is when the patient has any organic pathology. Here, we have an increased risk of colonization, and we will not have our therapies working. Here, we can find an anatomical disturbances, like it can be a diverticuli or a urine stone or a bladder problem or a prolapse or a huge prolapse in an immunocompromised patient, in a drug-resistant patient. This becomes a complicated UTI. So complicated infections we see commonly as acute cystitis in a non-pregnant patient. So it can be in pregnancy, it can be in perimenopausal age group, or even a young post-pubertal. We see an uncomplicated where this patient will come with a history of sexual intercourse, and there is a delayed post-coital bladder emptying, and they get these infections repeatedly. Even use of diaphragm or spermicidal contraceptives, they alter the normal vaginal flora and allow colonization. So these are the examples of an uncomplicated infection. And a complicated infection, we have already spoken in complicated patients like any organic problem. So we need to diagnose that. Secondly, we need to diagnose what is the recurrent UTI, reinfection, and persistent UTI. So recurrent UTIs occurs after documented infection has resolved. So you know patient, there is an infection which was documented, it has resolved completely and she comes back again, it is a recurrent. But reinfection, a new event with reintroduction of bacteria into the urinary tract. So reinfection is a reinfection with the same bacteria, but again a new event. And a persistent is the same bacteria which has persistent. There is no relief, but the infection is just persisting. So that is a persistent infection. So we really are important, because accordingly we need to give the duration of antibiotic course when we get these kind of infections. So perimenopausal, postmenopausal, we have spoken about the organic causes, diabetes, the incontinence, the overactive bladder, everything, whatever we spoke today. And these are the hygiene practice from the crux of everything. We always tell our patients to be hygienic. Menopausal patient, because of atrophic vaginitis, because of the raised posterior urethral valve, because of due to voiding dysfunction, which was discussed earlier. So all these are the risk factors to get UTI. And UTI is going to definitely have its implication, and the bacteria is going to colonize with all these factors what we have discussed, and it is going to get complicated. And when it is getting complicated, we know the pathogens we need to isolate and send a culture. And we need to check that these are the common cells, lactobacillus, staphylococcus, streptococcus, they are the common cells. But pathogens are our E. coli, almost 80%. Then comes Klebsiella, Pseudomonas, Staphylococcus, Enterococcus. So why pregnancy? It is more common. Why? Because the kidney size increases approximately 1.5%. There is a dilatation of the pelvic lysal system. So you can see it, giving a picture of an hydronephrosis. Also, there is increase in the GFR and the renal flow rate. So these are the physiological changes which occur. Also, the growing uterus will compress and displace the ureter laterally at the pelvic brim. There can be a hydroureter-like thing which can be seen because of the progesterone effect also. And it can also cause kinking of the urethra and lengthening of the urethra, which is common. So physiological changes do aid and aggravate the infection, which is, and this pregnant patient become more prone to urinary tract infection. Also, due to persistent pressure of the gravid uterus, there is marked thickening of the bladder trigone. You can see it is thickened. This also increases the bladder pressure from 8 to 20 centimeters of water. And due to the reason, there is significant vesico-urethral reflex causing ascending infections. That is the urinary infections. So we are worried in our pregnant patients who have high chances of urinary tract infections. So we need to test it. We need to identify whether it is a reinfection, whether it is occurring again and again in pregnancy. Each episode needs to be treated separately. We need to give antibiotics to this patient, and we need to check whether it is getting recurrent or not. And if recurrent, definitely the patients who are non-pregnant can receive a prophylaxis for 6 to 12 months. Nitrofluoride is a best drug which can be given to these patients. So when we talk, when there is a persistent infection, failure to completely eradicate, we need to really go and check if there is added anatomical cause, because we don't want to prolong the therapy, because you cannot keep giving antibiotics, but you need to then re-inspect, examine the patient and find out why our antibiotics are not acting. So when we talk about the 80% E. coli, we need to check the vaginal flora also, restore the flora, hydrate the patient and prevent reinfection. So when we talk about reinfection or a recurrent infection, that after 2 weeks, we really need to repeat a culture and verify whether the infection has gone completely or not. If the infection has gone completely, then we know that this UTI is treated, and again, if it comes back, it becomes a recurrent UTI. So why is the E. coli very common in intestine, and why it is always causes this complicated variety of UTI? The answer lies in biofilm. Biofilm, this is the E. coli forms a biofilm, a slimy layer on the bladder surface, which increases its adhesiveness and offer resistance to antibiotic penetration. And this makes the antibiotic action very, very weak. So this, how the biofilm formation is the cause for having recurrent UTI in such patients. And when we know these biofilms are there, patients also can have an interstitial cystitis, bladder pain syndrome, and the infection can remain for a longer time, even if the cultures become negative. So it is like a persistent infection which remains, and you may not get a positive culture also, but patient may be symptomatic within this condition. So the therapies, we know hydration, we tell our patients to drink a lot of water. We need to relieve the urinary tract obstruction at whatever level it is. If a foreign body or a catheter which is there present needs to be removed, because we need to treat the cause and remove it. And judicious use of antibiotics, because you need not start just empirically any antibiotic, but use it, all antibiotics, with caution. This is the examination finding which I had told you earlier. Do a proper urine test. Urine routine microscopy will tell you the leukocytes, epithelial cell, even there are RBCs, everything will be evident on a routine microscopy. And we need to even do diabetic screening, because these patients are having immunocompromised and raised sugars. They have frequent urinary tract infections. So diabetic control is very, very important when we're talking about reinfection and relapse. So this is the classification and the criteria for labeling UTI as per the American urology, European, Canadian, and almost all have said that presence of dysuria, foul smelling, pain, and hematuria and a fever. So they have classified as a UTI, and American Urology Association has said only dysuria, hematuria, and smell and pain. So by any definition, these are the definitions, and this is when it becomes a recurrent, because it occurs after a documented infection is resolved, and the Europeans chase at least 3 episodes in the last 2 months. So that is how all the guidelines are, comparison of all the guidelines which is there. So empirical treatment is allowed only if there is the same organism as per the American College, and most of the guidelines do not allow in complicated variety the empirical treatment with antibiotics, and culture becomes a must. And this is the anatomical problems, the voiding dysfunction, the bladder outflow tract, and all needs to be kept in mind. So midstream sample, which we said, but if there is persistent hematuria, we really need to do a renal imaging, need to do a cystoscopy in this patient. Prophylaxis, whoever require, we need to check on this, because we just can't keep giving prophylaxis, but we need to keep repeating the culture also till the culture becomes negative. And to the patients who get recurrent infections, post-coital antibiotics, they are the low dose for prophylaxis, which we can continue, and tell them that take it after the intercourse, and this is going to help from the post-coital urinary tract infections. The resistant infections, recurrence, non-pharmacological intervention and pharmacological, because we really don't want to keep the patient continuously on drugs. So what are the recommendations saying? The American, European, and the Canadian, they're saying vaginal douching, tampons, spermicidal, all nothing is recommended. They are not going to prevent. But in a menopausal patient, systemic HRT, low dose estrogen, or a roll of probiotics, or a cranberry, D-mannose, low dose antibiotic prophylaxis. So all this is there, but what is most recommended is the estrogen therapy and the supplement with D-mannose and postcoital antibiotics. So these are something which are recommended for the recurrent UTI. This is what is there. And how do you give the vaginal estrogen? By a cream form, daily for 2 weeks and twice weekly for 6 to 8 months. And this is what we can recommend. No recommendation of vaginal washes or long-term use of just only probiotic, but in conjunction we can give. We need to avoid fluoroquinolones. Definitely choice becomes a nitrofurantine. Safe, first line we can start at 50 to 100 mg dose, and that there is a role of fosfomycin. This is a newer drug, and we need to know that this drug given 100 mg BD for 7 days or maximum 3 gram. This is the nitrofurantine dose, and 3 gram per day single dose. This is the fosfomycin dose. We can give it, and it can be a first line treatment also in uncomplicated lower urinary tract infection. Avoid beta-lactamines and quinolones. So that is the message which all guidelines, even the European, the Infectious Disease Society of America, the European Society of Clinical Microbiology, Urological Association, all are in favor of not giving empirical antibiotics, but giving culture specific, and fosfomycin can be given the 3 gram oral sachet. It should be taken on an empty stomach 2 to 3 hours before or 2 to 3 hours after meals, preferably at bedtime and after emptying the bladder. You need to keep the concentration in the bladder and not to void immediately. So empty the bladder, then give the sachet, and we need to make the preparation in 200 ml of water and drink it immediately. And this is which is the treatment, a newer treatment for recurrent urinary tract infection, and also can be given for uncomplicated variety also. So asymptomatic, we have said, does not require a treatment, but we need to know if there is any immunocompromised status or high risk factor. But prophylaxis, you need to give all women with pre-pregnancy history of UTI, persistent symptomatic or asymptomatic bacteriuria after 2 courses of antibiotics. Then, sorry, I am going. 2 courses of antibiotics, and even after 1 UTI, if other risk factors are there, like diabetes, or the patient is having an immunocompromised status, and we can give prophylaxis post-coital. So use nitrochlorantine, fosfomycin, or cefalexin only if indicated, and we need to categorize the urinary tract infection in short from pregnant and a non-pregnant state. But in the non-pregnant state, we need to find out whether the patient is postmenopausal or perimenopausal. So premenopausal, you need to find out whether there are structural abnormalities or no. If there are structural abnormalities, treat them. And if there is postmenopausal, you can give vaginal estrogens. Yeah, we need to give low dose prophylaxis. Non-pharmacological measures like starting postcoital antibiotics, imaging if there is a urethral valve defect or you suspect any compression or anything, these patients should resort to imaging. So this is in short how we can go about systematically treating an urinary tract in pregnancy and out of pregnancy. And I'll end with a quote: whatever the mind of the man can conceive and believe, it can achieve. This is by Napoleon Hill. And at the end, just a humble request to vote and support me for the post of Vice President of FOXI from the West Zone. I'm your candidate. I want to work along with you and with you, and together we can work for FOXI. And that is my goal and my vision. And with that, I end my talk and thank you all for your patient hearing.
So thank you, Komal ma'am. So our blessings and wishes are with you. You will surely come up with flying colors. The result will come.
Thank you. Thanks,
so your talk. Yeah, your talk was also informative, very. So I would like to invite Dr. P Pallavee madam to please give the concluding remarks.
That was a wonderful talk, Dr. Komal. And I must congratulate Dr. Komal as well as Dr. Ruchika for bringing this webinar on a very important topic, urogynec. Often my students, when they pass out from the post-graduation, they ask me, Madam, in which field I should do my fellowship? So they give me only 3 options. They ask whether infertility, ultrasound, or endoscopy. I always tell them the other 2 options. You should go for either urogynec or surgical oncology. So we need to increase our expertise in this field. So I request Dr. Komal, as she's an active member of FOXI, to think about bringing this urogynec training courses under the ambit of FOXI, because I see only endoscopy and infertility and ultrasound under the FOXI training courses. So if we can put this course also, I think there will be a lot of new young upcoming physicians who can be trained in this field. And we have seen all the speakers and how we can make a great difference by treating these women who are suffering from all these different problems of SUI. So that was a wonderful talk. I have just one question, Madam. What is the role? Is there any role of vaccines for prevention of this recurrent UTI?
Vaccines? No, I have not heard of any vaccines per se. So much literature I have gone through, but there is no role of any vaccines. Which vaccines are you talking about?
No, there are some literature of upcoming vaccines which are available in the Western world, but I am not sure whether it has come to our country as of now.
Yeah.
So another thing, I just wanted to know what the regimen you have told for the starting the empirical treatment. Would you opt for a 3-day course or a 5-day course or a 7-day course? Because there is always a great confusion regarding the length of the
regime. Yes, there is a confusion in the length of the regime. If you feel that it is a completely non-complicated patient and they get infection, I think a 3-day is fine. Almost all guidelines have mentioned a 3-day. You do not give it for a longer time. But if a patient is getting a very long term, then that are the cases where the long term course is required. So 3 days should be fine for the.
Okay, ma'am.
Thank you, Anita ji. Thank you so much. Dr. Pallavi, thank you so much for being there present. It was lovely having you both chairing the session. And great pleasure. Ruchika, thank you.
Thank you,
It was wonderful hearing you, Dr. Komal. You really spoke so well on this very, very important topic. As ma'am, Dr. Pallavi also said, so much morbidity, mortality can be prevented if we just look into it, and prevention of UTI at a very basic level by even giving them menstrual hygiene in detail.
Yes.
You know, we just say menstrual hygiene. We don't tell them how many pads to be changed in a day, you know. the last days of the cycles, they are using 1 or 2 pads only because they feel there's hardly any blood coming out. So we have to really tell them in detail actually about these simple things, not to hold the urine and drink lots of water. Because many of the women are working now. So in the offices, they don't have problems. They don't have problems, So they are not able to go and pass urine, or they are not able to drink water. I'll tell you about one patient. She was from a very posh area in a greater class 1. She was in one complex, very shopping complex, very posh Archana shopping complex. And she was selling those these suits. And so she came to me. Imagine what she used to do. They didn't have good toilets over there. So she didn't want to go there. So she used to keep pads to pass the urine. And she came in such horrible situation, after so many months of using, because these are simple things, and people don't even share these things with anybody. So I was really shocked when I just saw all this happening. We have to be really very, very yeah. So we have to, yeah. So one has to be very, very verbal, loud in speaking about these small, simple things, which we presume everybody knows. And ultimately it comes to such. So your topic was wonderful, and you so clearly you told even phosphomycin is a wonderful drug. It really helps people a lot, and you have to just take once, and it's really comfort. Though it's a little expensive, and maybe now the rates are coming down. So thank you so much, and really wishing you all the best. Truly, you are going to come out with colorful colors, and you will be our vice president, and we'll do a lot of work together with you.
Okay, thank you. Thank you, Komal madam.
Yeah. Thank you. Yeah. Thank you, Dr. Ruchika.
Thanks, Dr. Ruchika, for lovely coordinating. Great.
Yeah, all this. Yeah. Thank you so much. Okay, bye. All the best.
Thank you all. Thank you, Shield Connect team, Saiti, Dr. Prachi. Yeah, thank you all.